What's up, Doc Mike? Public Health on Call, by Johns Hopkins Bloomberg School of Public Health. Today's topic for March 23, 2021. How the pandemic could help fix health care post-COVID-19. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Season 3 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call. Today, Stephanie Desmond talks to Dr. Melinda Bunton, a health economist at Vanderbilt School of Medicine, about what healthcare systems could look like post-COVID-19. They discuss the cracks that have been exposed during the pandemic and how we don't want to go back to business as usual, but to create something better. Let's listen.
Dr. Melinda Bunton, thanks so much for joining me.
I am delighted to talk to you, Stephanie.
So today I wanted to have you here to talk about the future of healthcare beyond COVID and the future of public health beyond COVID. I know that the COVID pandemic has really exposed fissures in the healthcare infrastructure and the public health infrastructure. And I'm wondering if you could sort of give me a lay of the land, what we've seen.
Absolutely. So what I hope the future of healthcare and public health, as you put it so well, is in this country is not what we've seen during the pandemic. So during the pandemic, we saw a healthcare system that couldn't respond well, where fee-for-service payment meant that providers were laying people off in the middle of a pandemic when they were needed. It meant that we had a situation where people lost healthcare coverage when they lost their jobs and were afraid about accessing care, a situation in which care was very expensive, a situation in which our public health infrastructure was not up to the task, and one in which we were trying desperately to cobble together data sources to even understand the pandemic as it was unfolding. So all of those things were exposed. And then, of course, layered on top of that was the tragic inequities in healthcare, underlying healthcare that were exacerbated by the pandemic. So when we take all these things together, we know what we don't want our future healthcare to look like. It does point to what we do want our future healthcare to look like, which maybe I can elaborate on.
Yeah. So how can the United States emerge stronger from this?
Well, I think the United States can emerge stronger from this by focusing on those areas I just mentioned. So we do have a new Congress and a new administration. And of course, their first order of business is dealing with the pandemic. And in doing so, they are putting in place provisions to, for example, help families afford healthcare coverage on the exchanges. I do think the new administration is very committed to equity. I think that they are also committed to being data-driven. And so I think that there will be some changes as a result of the pandemic and what we've learned in those areas. We also need to not just go back to business as usual, though. I think I'm eager to go back to business as usual in some arenas, but I'm not eager to go back to business as usual in healthcare because it was so expensive, so inequitable, wasn't covering people, and all of these things. So I think we need to figure out how to build back stronger. I know that's something people say. But what I mean is take a very good hard look at what worked during the pandemic. And so, for example, there were healthcare physicians, medical groups, hospitals that were part of accountable care organizations that were better assured that they would continue to be paid, even when their patients couldn't come in and see them in person. And I would like to see that type of payment system emphasized in the future because I think it will lead to a more resilient healthcare system.
You're talking about telemedicine there.
I'm going to get to telemedicine in just a sec. Yeah, thank you for asking. Telemedicine, I think, needs to be, we need to learn what worked in terms of telemedicine. We did too much telemedicine because we had to, in a way. We need to find the right amount of telemedicine. And I think we'll probably end up that maybe half of the visits that used to be in person can be done well through telemedicine, but the other half can't. And we need to find that balance, figure out what works, and be stronger for it. Another thing is data systems. It sounds really geeky, but if we don't know, if we don't know the characteristics of people, where they live, what their needs are, whether they've gotten the care they need, the vaccine, et cetera, then we can't plan to use our healthcare resources well. And we, in the current system, everyone who touches a patient really even tries to guard that data and make sure other people don't see it, because there's a competitive advantage to having data on patients. And I think that's a shame, and we need to figure out policies that move beyond that. So those are just a handful of examples. I don't want to ramble on, but of ways that I think we need to build back better, given what we've seen during the pandemic.
Mm-hmm. And I know that you feel as though we've been a lot more agile in our change as we thought we could be.
Absolutely. So talking about telemedicine, we saw, as much change as I might have expected could occur over a decade in telemedicine in the space of 2.5 months, probably. Mm-hmm. Now, that's fantastic. And as I was just saying, I think the answer there is to figure out what the correct proportion of our visits can be telemedicine is. But we showed we could do it. Care teams did amazing things. I work at a place where there were so many heroes who figured out so many ways to get personal protective equipment, allocate it properly, take care of patients as the medical knowledge was evolving hour by hour. It was astounding what we saw. And I think we need to learn from that too. And one of the things I hope we learn is that during COVID, people really had to practice medicine in teams. And they had to, each person on that team had to do as much as they could, really practice, as we say, to the full extent of their license. And that's something I'd like to see more of in the future, as opposed to us going back to more traditional roles, where this is the role of the nurse or the physician's assistant versus the physician or the resident on any care team. And so, for example, nursing and pharmacy, I think, played a huge role.
In what way?
They played a huge role in terms of being part of those critical care teams and making sure that in these circumstances where resources were stretched to the limit, patients got what they need. We also saw that physicians were able to relieve each other. They could be trained up so that they could assume new roles. So, for example, in anesthesia, people could assume new roles in critical care for COVID patients than we might have thought they would be able to do. So just so many examples of innovations. I know of some from my local area, but I talked to colleagues and I had some colleagues who interviewed people across the country for an editorial that I was part of. And they just came with so many amazing stories that it made us feel hopeful about where we'll end up after this pandemic.
One thing I wanted to ask you about, because this is top of mind for me and probably a lot of people, is sort of this lack of public health infrastructure when it comes to vaccines, because that's all we're talking about right now. Of course, have you gotten, do you have an appointment? Are you getting an appointment? That kind of stuff. Mm-hmm. And it really just says, you know what? We as a country don't do mass vaccination campaigns. We do flu shots, and not everybody gets them, and not everyone gets them on the same day. And we have childhood immunizations, but some of that's given at the health department, and some of it's given in the doctor, private pediatricians' offices. So, sort of no wonder we have this problem. We didn't really have an infrastructure for vaccines. I guess we're seeing that develop much more quickly than we could have imagined, however.
Well, so many things are happening so much faster than we could have imagined. I mean, we were literally delivering vaccines to people 2 days after they were approved, I believe. That's astounding, right? And the fact that they were developed so quickly, that's astounding. And you're right, in general, we don't do mass vaccinations in this country. Now, I happen to work at Vanderbilt University Medical Center, and every year at Vanderbilt, we run something we call Flulapalooza. And we literally held the Guinness Book of World Records for the record number of people immunized in any single day. This is a medical center with over 25,000 employees. They're all required to have a flu shot. And I think nearly 20,000 were immunized in one day. So this can be done. And in fact, my colleagues who ran it have written, academic articles about it. And so there's a playbook for how to do it. That playbook has not been picked up by any official capacity, but we can do it if we need to do it. We're not used to doing it in this country. And I think there are a number of reasons why that is. First of all, we've been lucky enough not to have to do it. Second of all, we are just at a moment culturally where we have a lot of people who are distrustful of vaccines. It's been very unpredictable to figure out how many people actually want to take up the vaccine. So while people like you and I may be dying to get our vaccine and get our parents in line for it and things like that, that's just not universally true. And there are different groups of people who have very different reasons for being, as experts would call it, vaccine hesitant, or just concerned about being, especially among the first dose of people to get a vaccine. So all of this has really hindered rollout, which doesn't, excuse the fact that mistakes have been made. And in hindsight, we could have done a better job. But I think going forward, which is really where your question was, going forward, we need to have plans in place. Mm-hmm. We can't expect that this will only happen once in 100 years just because the last time something like this happened was 1918. It could happen sooner. And although it's not, appealing for a politician to invest in this type of stockpiling and preparing, they would rather, offer some more tangible benefit to their constituents. It has got to be done. And so what I truly hope is that we can find a way independent of the stresses and strains of the federal budget process and passing laws to make sure that public health is protected.
So what's the first thing we do to move forward once this is sort of over? How do we take the best of what we learned and move forward to, much better than business as usual?
So especially when government is involved, one of the things we've done, and it has worked in the past, is put together a certain type of expert commission. Now, some people might roll their eyes, why do we need commissions? But there have been commissions that have been very successful and not even in the distant past. So I'm thinking about things like the 9/11 Commission, which really examined all the events around that, and out of which grew the Department of Homeland Security. When tough choices have to be made, there are things like the Base Realignment and Closing Commission, which was insulated from political pressure to make hard choices about where military installations would be. I think we need a commission like that. And I wouldn't even necessarily wait until the pandemic was over. I think maybe they need to start gathering information now. And we need to let a group of top-notch, unconflicted, and politically insulated individuals give us some strong recommendations. And then we need to follow through on putting the money behind them.
Well, Dr. Melinda Bunton, this has been an excellent conversation. Thanks so much for joining me.
Thank you for having me. Enjoyed it.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, C.N. Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.